Hi guys, it's Professor Costa. I'm back with Oxygenation Part 2. Um, so now we're going to talk about, we were talking about clinical manifestations of hypoxemic or low oxygen acute respiratory failure. Now we're going to talk about hypercarbic or high CO2 levels, all right? And the problem here is that CO2 can't get out. It can be caused by a low respiratory rate. Sometimes we do this with vent settings inadvertently, but it's usually caused by obstructive disease such as COPD or obstructive sleep apnea. Manifestations. If we have acute respiratory failure, usually we'll have a decreased SpO2, a decreased level of consciousness or a headache, drowsiness. The higher your CO2 level goes, the more likely you're going to have a change in level of consciousness. So drowsiness may be severe, or they may even be, unresponsive. And abnormal ABGs. So we're going to have hypercarbic, so we're going to have a high CO2 level, so it's going to be greater than 45. And that's usually accompanied by an acidosis, all right? Remember, the lungs controlled CO2. So if we have a high CO2 level and we have an acidosis, then that's a respiratory acidosis. The fix, because we have respiratory failure, we're going to be giving them oxygen as well. Though if it's, not severe, we're going to be really careful with this if they're a CO2 retainer with our COPDers especially. And we're going to improve exhalation either through meds or pursed-lip breathing, a CPAP if it's caused by obstructive sleep apnea, or in some cases we may need something a little more, invasive, so BiPAP or mechanical ventilation with an increased respiratory rate to blow off excess CO2. So depending on, what's going on with the patient, we may have to be a little more aggressive. So we're going to follow the ABCs here. Airway, breathing, circulation. These are our priorities here. So interventions for the initial management of respiratory distress or failure. If our patient says they can't breathe or they don't appear to be doing the work of breathing, our first check is airway. We want to keep the airway open with the head tilt, chin lift. Or if we're suspecting a neck injury or something, we could do the jaw thrust. We're going to clear the airway as needed, and we may insert an oropharyngeal airway or a nasopharyngeal airway. We'll look at that on another slide, what those look like. We want to make sure the airway stays open. If the patient has an intact airway, but they're having trouble breathing, or they're having both, we definitely want to monitor oxygen saturation, which is the pulse ox, provide oxygen as needed. If they're in respiratory distress or failure, so if you have a patient who's really, they're not breathing well, I can't breathe, or they don't appear to be doing a lot of great work themselves, a non-rebreather is the preferred delivery. So if I have a patient in respiratory distress, again, I'm not going to put on a pulse, a nasal cannula and give them 1 liter. I'm going to put on a mask and I'm going to crank that up to make sure that I bring the patient back from the brink. Because if they go from respiratory distress or failure, they're going to be dead pretty quickly, okay? We're going to give them inhaled meds as needed. We're going to assist ventilation if we need to. So if they're not breathing enough, like their respiratory rate is below 10 and they're in a respiratory distress, we would, consider definitely if it's below 8, we're going to be bag valve mask. We're going to be using that ambu bag. And we may prepare for endotracheal intubation, right? If there's an airway issue or they're not breathing sufficiently for long enough, we may decide if we can't reverse it that we're going to have a machine do the breathing for them. And circulation, we're going to monitor heart rate, the rhythm, the blood pressure. We're going to place in an IV, right? We're going to support circulation as much as possible. All right. So oxygen delivery systems. Now I've been teaching this content for years now, and it never ceases to amaze me how little students know about delivery of oxygen. So if I want to deliver oxygen by nasal cannula, I should know roughly what percent FiO2 that means, right? So remember, room air at sea level, like, if I'm living in Rhode Island, we live at sea level, that's approximately 21% FiO2. So you and I sitting, in Rhode Island during the summer, we're breathing about 21% FiO2. For every liter you add nasal cannula, you're adding between, 3 and 4%. So, adding 1 liter is around 24, 25%. 2 liters is around, 28, 29%, ballparking it. The maximum amount of O2 that you can deliver by nasal cannula is 6 liters, and that's around 45%-ish, okay? Now, when we move to a simple face mask, we pick up where we left off. It's 6, the minimum delivery of oxygen that you can deliver. Like, you cannot deliver less than 6 liters per minute by mask, or all your patient is going to be breathing is their own expired CO2. There isn't enough flow at less than 6 liters a minute. So if you're using a mask, you better be at least 6 liters, or you're just causing more of a problem. And 6 liters by simple face mask, because there's like holes and stuff, is about 35%. So know what you're using to deliver the oxygen and what it's capable. So if you have a patient that's on one delivery device, know what the FiO2 is, because if you're switching to another delivery device, they're not all equal, right? So for instance, a non-rebreather mask, the bag at the bottom of the mask fills up with a reservoir of 100% oxygen, which is why we call it 100% non-rebreather mask. Because if the bag is full of oxygen from the wall, then every breath that the patient takes is a one-way valve, will have 100% O2. So it's as close as you can get to 100% using a mask, okay? So it's the highest. So if my patient's in respiratory distress, guess which one I'm going for? If I'm going to put the forest fire out first. I'm going to stick this kind of mask if I have it, crank the O2 up, and hope that we reverse this respiratory failure for whatever reason, right? So if my patient's turning blue and they're not breathing, well, but they still have a respiratory effort, like you can see chest movement, we're going to go for a non-rebreather. If my patient is turning blue and they're not breathing enough, then I'm going to go for a bag valve mask, right? So my opioid overdose, the problem isn't, really that the oxygen delivery, it's just that the breaths aren't happening, so you have to augment breathing with rescue breathing. At the bottom, we have a really handy-dandy item called a Venturi or a Venti mask. Venturi is a brand name. So a Venti mask is, this is what I mean by making sure you know what your patient is on before you switch devices. So let's just say that I'm carefully titrating my COPD patient's oxygen delivery. So I see that the blue one delivers 24% FiO2, which is approximately the same rate as 1 liter nasal cannula, but it's able to deliver it in mask form. And you may say, well, Professor Casa, why wouldn't I just stick them in a nasal cannula? Well, not all of our patients breathe through their nose. Maybe they have a broken nose. Maybe they're COPD or has a severe sinus infection. I don't know. Also, a Venturi mask does allow for careful titration. It's a little more precise. So if you really want a good idea of how much oxygen your patient is requiring, then you would use a Venturi mask. Remember, because people talk or they eat or they may take a few breaths out of their mouth and not their nose, or the nasal cannula is not as precise measurement of how much oxygen they actually need. A Venturi mask is. All right. Are we losing our airway? So here's some things. So do we have severe wheezing or decreased breath sounds, or are they turning blue? Can you see their ribs retract because they're struggling to breathe? Is there a tracheal tug? That's that little gap. You see the right at the neck. You see the air getting like almost like they're trying to do their own trach. Is there an inspiratory stridor, like that horrible croaking, sound? Is there gurgling or a change in their voice or a poor chest expansion or drooling? Okay, if we think we're losing our airway, if we suspect an airway closure or an obstruction, call for help. Airway closure is an emergency. That's the A in our ABCs. It's great. We're not going to leave the patient, but we don't have the ability to put in an advanced airway as an RN. Okay, so airway closure is an emergency. We need someone who can put in an airway now. So an MD, a PA, an NP, or in the world of NCLEX, it might be listed as a licensed independent practitioner or an LAP. We need a doctor, right? We need somebody who can put in an airway now. We're not going to leave the patient, and we're going to try and maximize breathing as best we can with other things. But the first thing we should help. That's the blue in code blue, right? Are we losing our airway? We need help now. So an upper airway obstruction. So we have tongue edema from allergies or trauma, thick secretions, trauma to the face or trachea, epiglottitis, cancer, smoke inhalation. So if it's an upper airway or we're choking, we may need to bypass that using an endotracheal tube or a cricothyroidotomy or a tracheotomy, right? So if there's something up in, the tongue's completely swollen shut and they can't breathe, we may have to bypass that and go below and put in another airway. So airway issues, what do you do to help arise? So if we have an airway issue, we're calling for help, and then in the meantime, we're going to try and keep this guy alive, right? So we're going to keep the airway open with a head tilt, chin lift, unless they have some kind of neck injury or suspected neck injury, right, or spinal cord injury. If that happens, we're going to use the jaw thrust. We're going to clear the airway if we can, and then we may put in an OPA, which is the oropharyngeal airway, or a nasopharyngeal airway as needed to keep the airway open. Again, if you suspect they're losing their airway, call for help immediately. Patient may need an artificial airway. Do not leave your patient. You're going to try and maximize the airway using the above interventions while you wait for help. And here's one of those critical rescues, though. If your patient's been complaining of the worst, horrible, most awful, severe sore throat they've ever had, and you suspect something called epiglottitis, where they're drooling a lot, don't try to suction the patient or place anything inside the mouth, because if they have a really, really bad sore throat, they could have a spasm and it could close off the airway completely. So if you think it's because they have a severe, really, really bad sore throat, that would be one of those critical rescues where we wouldn't suction. Otherwise, we may suction them. All right, so inserting an OPA or an oropharyngeal airway skill, it allows suction, which is nice. It's really cheap. They're only like 75 cents each, and they are a life-saving thing. Maintenance of airway patency, and this is a skill you're going to look up in your skills book. I don't remember if skill 27-1 is the one from Mosby or if it's the one. You're going to go in whatever skills book you have as a student, and you're going to look up inserting an oropharyngeal airway. And you're a grown-up student, you can look this skill up. The point is to pull the tongue forward and keep the airway open. If it's too small or too big, you can actually be making the problem worse. All right, so you're going to select the size of the patient based on the age and anatomy, and you're actually going to look that skill up in your textbook. Okay. All right. So what happens if we need to actually intubate or put an endotracheal tube in? This is an advanced procedure. Again, usually if the patient is awake enough or capable, the MD, the physician, is going to explain the procedure to the patient. Unless the patient is dead and we're doing compressions and trying to save their life, then we're going to assume, unless they have an advance directive, that they want to be intubated. We're going to remove their dentures. I can't tell you how many patients I've had over the years where they do the x-ray and they find dentures down in the throat because they didn't take the dentures out. So you want to inspect the teeth and look at the dentures. We're going to pre-oxygenate them, meaning we're going to give them 100% FiO2 for a short period before the procedure, because we're going to paralyze and put them to sleep, and they're not going to be breathing on their own. So we want to pre-oxygenate the patient. Patients will need to be sedated first and then paralyzed. Never the other way around. That would be horrible. So we want to sedate before we paralyze. So we're going to give, most of the time we sedate them with something like a benzodiazepine, lorazepam, diazepam, an opiate like fentanyl, or a general anesthetic, propofol or etomidate. And then they get paralyzed, vecuronium or succinylcholine. So why are these listed? If you know you have to sedate the patient first and then paralyze them, then you should know the difference between the medications. So these are the usual suspects, okay? So you should know that vecuronium is a paralytic and would be given after the opiate, like fentanyl, all right? Etomidate and sucks are kind of a normal cocktail that doctors like to use. So you may see etomidate followed by succinylcholine. So you would give the etomidate first. All right, intubation equipment. So there's all types of, I know there's a lot of information on this slide. So starting at the top, we have an endotracheal tube, which is called an ET tube. ET tube. They come in different sizes. Most adults are between a size 7 to 8.5. They come in all sizes, little itty bitty baby ones, and most adults are, 7.5. A smaller woman, you might see a 6.5 or a 6. The ET tube above, it's a flexible piece of plastic, right? Like a straw, thick straw. In order to insert it without bending it or kinking it off, it comes with something called a stylet, which is basically a bendy, slightly bendier than a coat hanger, for want of a better description. But the stylet stays inside the tube, and you can, it's semi-rigid, meaning they can bend it as they're trying to insert it. Once the tube's in place, the stylet comes out, all right? So that's only used for the actual intubating procedure. Then you'll see all those little silver things. Those are the two in the middle are the laryngoscope, and then there's the blades. So there's two main kinds of blades that are used in practice. The straight are called the Millers, and the curved are called a Macintosh, or Mac for short. All right, and the only way I remember the difference is, and this is what stayed with me. Macintosh apples are round, so the curved ones are Macs because they're curved like an apple, if that helps. And the Millers are straight, and the physician that's doing the procedure, or the nurse practitioner, or the whoever's doing the intubation will ask for the size. Okay, so they'll say I want a 4 Miller or a 3 Mac, and the nurse has to make sure that the light works. There's a tiny little light bulb on the end. And when you're giving this to the practitioner, you want to make sure that the light bulb works as you're handing it off. All right, once the ET tube's place, we often use an oropharyngeal airway as something called a bite block. So remember, the ET tube itself is like a thick straw, and people have teeth, and sometimes people chew on the tubes and break them off. So oftentimes we will put in an oropharyngeal airway not so much to keep the airway open because we already have an advanced airway, but to prevent the patient from biting through the tube, okay? And sometimes we just have one in place before they're intubated to keep the airway open. So sometimes they're already there and then we just keep it in, or sometimes we choose to place one in after intubation. Once the tube's in place, there's a balloon on the end of the tube that is inflated, and that is to prevent secretions. One, it helps stabilize the tube and keep it in place, but two, it also prevents secretions from coming down into the trachea. And it's used using it's inflated using a 10 ml syringe. All right. And then some kind of securement device, tape, or a special like Velcro or felt, or, there's all types of, securement devices, but you have to, once you know the tube is in the right place, you want to keep it there. There's also something called a laryngeal mask, or an LMA, and that doesn't go through the vocal cords. It sits right above them, and it's basically it's a fancy mask that goes and sits right above the larynx, right? So, and there's also intubating versions where they have another hole in the middle. So you can start ventilating the patient using the LMA, and then there's another hole in the middle where you can actually intubate through it. How do we verify advanced airway placement? First things first. Now, we've emergently put in an airway to keep someone breathing, right? We don't always have the luxury, and remember, time is oxygen here, to verify with a chest x-ray and waiting for that to develop. So the first thing we're going to do is we're going to take out our trusty stethoscope and we're going to listen. If the patient's intubated correctly, you're going to hear good lung sounds. Now we're not, this is a textbook picture, but we're going to listen to all the we're going to listen to the front and if we can posterior, and we're going to listen. And if we have good placement, we'll have good air movement and we'll be able to auscultate lung sounds. We also have something called a CO2 detector that we can stick on the end of the tube. And while we're ventilating, if there's CO2 coming out, it changes the color to yellow. And if there's CO2 coming out, then it's not in the stomach, it's definitely in the lungs. So that's a quick cheat to see if the patient hasn't accidentally, we haven't intubated their stomach instead of the lungs. X-ray confirmation. So how do we verify the tube's in exactly the spot we want it to? That's where X-rays come in. We would check, if you want to see the X-ray on the right, you can see that the tube is actually aiming to the patient's right side, and it has to be pulled back a little bit, right? You want the tube to sit and oxygenate both sides of the lung, and if we advance it too far, side and not go to the other. All right, another thing that we do is end-tidal CO2 monitoring, or a capnogram. And that's another way. So if we have an endotracheal tube that is in the right place, then we can we can measure levels of expiratory CO2. That's the end-tidal CO2. So if you have gas exchange occurring, then you should have a certain level of carbon dioxide coming out with each breath. And we have special sensors that can sense how much CO2 is coming out. End-tidal CO2 is really great with chest compressions too in a code, but for a different reason.